neratinib is a oral pan-HER tyrosine kinase inhibitor. So it inhibits HER1, HER2, and HER4, and because it's inhibiting those, HER3 can't work either. So it's basically a pan-HER inhibitor that is FDA approved in the adjuvant setting for high-risk HER2-positive breast cancers. In ExteNET, the women were randomized to a year of neratinib versus a year of placebo, along with their endocrine therapy if they were ER positive, and the results were positive in the intent to treat overall population. The hazard ratio for invasive disease-free survival at the 5-year mark was in the 0.73 range, about a 27% reduction in the risk of recurring with invasive breast cancer, local, regionally, or metastatic. Interestingly, the benefit was much greater in the estrogen receptor positive patients, with hazard ratios at 5 years in the ER positive patients in the 0.57 range or so. So now we're more than a 40% reduction in the risk. Interestingly, there was a cohort of patients who had received preoperative chemotherapy and trastuzumab, and they did not have a pathologic complete response. And so their physicians were interested in enrolling them in a trial because they were high risk, and they finished up their year of trastuzumab and were randomized to neratinib versus placebo. And that was a very positive trial, particularly in the ER positive patients, where it was about a 40% reduction in risk in patients in the preoperative setting. So this patient's very similar to that. She still had residual disease. Yes, she had the benefit of switching over to the TDM1 because she received preoperative trastuzumab and pertuzumab was not part of the standard of care at the time the ExteNET trial was done. Because she still had residual disease, we know that the trastuzumab and pertuzumab were not perfectly effective for her. So we also know that she will benefit if she switches over to TDM1, which she did. But we also know from the Catherine trial that there's still residual risk. We know that. And so we want to just utilize what we have. And the neratinib works very, very differently than the antibodies. The TDM1 delivers a cytotoxic agent. The pertuzumab, trastuzumab interrupt HER2 signaling and stimulate ADCC, an immune response. But nothing's getting at the tyrosine kinase end of signaling. And so it works very, very differently. We know there's preclinical synergy between inhibition of the estrogen receptor and inhibition of the HER family. If you inhibit just the estrogen receptor, you will upregulate the expression of the HER family, which of course could lead to recurrence, and vice versa. If you just use neratinib, you will upregulate the estrogen receptor. So, of course, combined blockade is highly synergistic preclinically. And in the patients who received preoperative therapy, had residual disease, and went on to receive neratinib, who were estrogen receptor positive, at 5 years, it was an absolute benefit of 7.4%. It was even higher in patients whose HER2 was centrally confirmed to be positive, even higher. So we're looking at 8% absolute gain. And I believe that neratinib is highly likely to be non-cross resistant with pertuzumab and with the TDM1. So I actually think it's very, very important for patients to have the opportunity, if they're high risk and still have 10% or more residual risk of recurrence at some point, we should do everything we can to reduce that risk. In ExteNET, no doubt the patients whose breast cancer was estrogen receptor positive had the greatest benefit from combined ER and pan-HER inhibition with neratinib. But in the ER negative group, if you look at the patients who started the neratinib within a year of finishing their adjuvant trastuzumab, and particularly within 6 months of finishing their adjuvant trastuzumab, which of course is what we would do, there'd be no reason to wait. Those patients, there's a separation of the curve, and the curve stays apart. It's about a 2.5% absolute benefit with the neratinib. So it can be beneficial as well to high-risk ER-negative patients. And I wouldn't hesitate to do that because the curves do pull apart in patients who started the neratinib soon after finishing up their year of trastuzumab.